In-depth look at heart health, cholesterol, calcification, infarction, and scars. Understanding the intricacies of heart health requires a nuanced grasp of various conditions and processes. This article offers an in-depth exploration of cholesterol buildup, arterial calcification, myocardial infarction, and heart scarring, detailing their mechanisms, how they relate to one another, and the rationale behind modern treatments. Cholesterol buildup, atherosclerosis, a chronic inflammatory process. Atherosclerosis is not merely the passive deposition of cholesterol, it's a complex, chronic inflammatory process involving the artery walls. Mechanisms of plaque formation. It begins with endothelial dysfunction, often due to factors like high blood pressure, smoking, or high LDL cholesterol. LDL particles enter the artery wall, become oxidized, and trigger an immune response. Macrophages engulf these oxidized LDLs, becoming foam cells, which contribute to the fatty streak, the earliest lesion of atherosclerosis. Over time, smooth muscle cells migrate into the intima, inner layer of the artery, and deposit extracellular matrix, forming a more complex plaque with a lipid-rich core and a fibrous cap. How medications reduce and prevent plaque. Statins. These inhibit HMG-CoA reductase, a key enzyme in cholesterol synthesis in the liver, leading to lower LDL levels. Beyond lipid lowering, statins also have pleiotropic effects, including reducing inflammation and stabilizing plaques, making them less prone to rupture. Ezetimibe inhibits cholesterol absorption in the intestine, further lowering LDL. PCSK9 inhibitors increase the number of LDL receptors on liver cells, leading to more efficient removal of LDL from the bloodstream, resulting in significant LDL lowering. As of 2025, oral PCSK9 inhibitors, e.g., MK-0616, are in late-stage development and may soon offer a convenient alternative to injectable options. Bile acid sequestrants bind to bile acids in the intestine, promoting the liver to produce more bile acids from cholesterol, thus lowering LDL. Lifestyle modifications, a diet low in saturated and trans fats, regular exercise, and smoking cessation directly address the risk factors that promote endothelial dysfunction and lipid accumulation. 2025 update: personalized cholesterol targets. Recent guidelines emphasize a more personalized risk-based approach rather than rigid LDL targets. Treatment intensity is adjusted according to the individual's risk of future cardiovascular events, which may include factors such as inflammation markers, coronary calcium scores, or lipoprotein A levels. As these plaques mature and become more complex, they may undergo calcification, a process once thought to be passive but now understood to be biologically active. Calcification, hardening of the arteries. Arterial calcification is a complex process where calcium phosphate crystals deposit within the arterial walls, often within atherosclerotic plaques. Mechanisms of calcification. It's not simply passive calcium deposition. It involves active biological processes similar to bone formation, with cells like vascular smooth muscle cells undergoing osteogenic differentiation, transforming into bone-like cells, and producing the necessary proteins for mineralization. Inflammation plays a significant role in this process. How medications manage calcification. Currently, no medications directly reverse arterial calcification. However, managing the underlying drivers of atherosclerosis and inflammation is crucial. Statins, by stabilizing plaques and reducing inflammation, they may indirectly influence the progression of calcification. Blood pressure medications, controlling hypertension reduces mechanical stress on the arterial walls, which can contribute to both atherosclerosis and calcification. Emerging investigations, New research is evaluating inhibitors of calcification pathways, including agents targeting bone morphogenetic proteins, BMPs, and phosphate handling mechanisms. Procedural interventions. In cases of severe calcification hindering blood flow, procedures like rotational atherectomy can physically break down the calcium deposits to facilitate angioplasty and stenting. In 2025, intravascular lithotripsy has gained ground as a novel option, using sonic pressure waves to fracture calcium and improve stent expansion. Severe or unstable plaques, especially those with significant calcification, are prone to rupture, leading to acute events like myocardial infarction. Infarction, myocardial infarction, the acute crisis. A myocardial infarction, heart attack, occurs when blood flow to a part of the heart muscle is severely reduced or blocked, most commonly due to a thrombus, blood clot, forming on a ruptured atherosclerotic plaque. The cascade of events. Plaque rupture exposes thrombogenic material, leading to rapid platelet aggregation and thrombus formation. This blockage deprives the downstream heart muscle of oxygen and nutrients, leading to cellular injury and death, necrosis, if blood flow isn't restored quickly. Immediate and long-term management. Emergency treatment focuses on rapidly restoring blood flow through thrombolytic drugs or percutaneous coronary intervention, PCI, such as angioplasty and stenting. Medications like aspirin, nitroglycerin, and oxygen are also administered. Secondary prevention. After the acute phase, long-term management aims to prevent future events and manage the damage. O-beta blockers reduce myocardial oxygen demand and the risk of arrhythmias. OACE inhibitors/ARBs reduce remodeling of the heart and the risk of subsequent events. O-statins address underlying atherosclerosis. O-antiplatelet drugs prevent further blood clots. O-cardiac rehabilitation helps patients recover and adopt heart-healthy lifestyles. Update on post-MI care, 2025. Dual antiplatelet therapy, DAPT, durations are now being tailored based on bleeding and ischemic risk. SGLT2 inhibitors are being studied post-MI for their potential to reduce subsequent heart failure development, even in patients without diabetes or pre-existing heart failure. The damage caused by an infarction initiates the heart's reparative processes, but often results in permanent structural changes, such as scarring. Heart scars, myocardial fibrosis, the heart's remodeling after injury. Myocardial fibrosis, or heart scarring, is the pathological accumulation of collagen and other extracellular matrix components within the heart muscle. This typically occurs as a reparative response to injury, such as that caused by a heart attack, myocardial infarction, or inflammation, myocarditis. However, chronic stress and disease can also lead to fibrosis. Mechanisms of scar formation. Following injury, inflammatory cells infiltrate the damaged area. Fibroblasts, activated by various signaling molecules, including angiotensin II and aldosterone, proliferate and deposit collagen to provide structural support. While initially beneficial for healing, excessive or persistent fibrosis impairs the heart's function. Scar tissue lacks the contractile properties of healthy cardiomyocytes, heart muscle cells, and can also disrupt electrical signaling. Why current medications don't remove established scars. Established scar tissue is composed primarily of dense collagen fibers, which provide structural integrity but are not living, contractile muscle cells. Current medications primarily work by influencing ongoing biological processes. They can modulate signaling pathways that contribute to further fibrosis, as seen with ACE inhibitors, ARBs, MRAs. Reduce the workload on the remaining healthy heart tissue, as with beta blockers. Address underlying conditions that can exacerbate heart disease. However, these medications do not have the mechanism to break down and remove the already formed, dense collagen matrix of a mature scar and replace it with functional cardiomyocytes. The body's natural healing process, once a scar is formed, generally maintains that structural change. The vicious cycle with heart failure. Heart scars can lead to or worsen heart failure by reducing contractile function, increasing stiffness, causing electrical instability, promoting ventricular remodeling, and increasing the workload on healthy tissue. Conversely, chronic heart failure can also contribute to further fibrosis through chronic inflammation, neurohormonal activation, ongoing myocyte loss, and volume/pressure overload. This creates a vicious cycle where scarred tissue promotes heart failure, and heart failure promotes more scarring, leading to a progressive decline in cardiac function. Management, not removal. Given the limitations in removing established scars, current medical treatment focuses on managing their impact and preventing further progression. ARNIs. By inhibiting neprilysin, ARNIs increase the levels of natriuretic peptides, which have antifibrotic and vasodilatory effects, complementing the angiotensin receptor blockade. ACE inhibitors and ARBs. These block the renin-angiotensin system, RAS, reducing levels of angiotensin II, a potent stimulator of fibroblast activity and collagen production. They also help reduce afterload on the heart, lessening the strain on both healthy and scarred tissue. Beta blockers, while primarily known for reducing heart rate and blood pressure, they can also attenuate the neurohormonal activation that contributes to fibrosis and remodeling. Mineralocorticoid receptor antagonists. By blocking aldosterone, these drugs reduce sodium and water retention, as well as the direct profibrotic effects of aldosterone on the heart. SGLT2 inhibitors. Emerging evidence and updated 2025 guidelines support the use of SGLT2 inhibitors, e.g., dapagliflozin, empagliflozin, not only in diabetic patients but also broadly in those with heart failure, regardless of ejection fraction. These agents reduce inflammation, oxidative stress, and fibrosis, and are now considered a cornerstone in heart failure management. The future. Investigational therapies. The quest to directly target and reduce heart scars is ongoing. Antifibrotic agents, e.g., pirfenidone. These drugs, used in other fibrotic conditions, are being studied for their ability to inhibit collagen synthesis and fibroblast proliferation in the heart. Galectin-3 inhibitors. Galectin-3 is involved in inflammation and fibrosis. Inhibiting it has shown promise in preclinical studies to limit excessive scarring. Stem cell therapy. The hope is that transplanted stem cells can differentiate into new cardiomyocytes, replacing scarred tissue with functional muscle. However, the efficacy and mechanisms are still under investigation. Gene therapy. Approaches to deliver genes that promote angiogenesis, new blood vessel formation, or inhibit fibrotic pathways are being explored. The interplay. These conditions are not isolated, they form a continuum of cardiovascular disease. Cholesterol accumulation and arterial calcification foster plaque formation, which can rupture and trigger infarction. The heart's attempt to heal post-infarction leads to scarring, which further affects the heart's electrical and mechanical function, potentially contributing to heart failure and increasing the risk of further cardiac events, creating a vicious cycle of damage and dysfunction. Understanding this cycle underscores the importance of early and comprehensive management. Proper and timely intervention at each stage is key to breaking or slowing the cycle and preventing the progressive decline in cardiac function. Addressing cholesterol, managing blood pressure, preventing infarctions, and treating heart failure are all crucial steps in this process. Conclusion: a holistic approach to heart health. The in-depth exploration of cholesterol buildup, arterial calcification, myocardial infarction, and subsequent heart scarring reveals the profound and intricate nature of cardiovascular disease. While each condition presents its unique challenges and mechanisms, their interconnected progression underscores a critical truth: heart health demands a holistic and continuous management strategy. Significant advancements in medical science, from personalized cholesterol targets and targeted pharmacotherapies like PCSK9 and SGLT2 inhibitors to innovative procedural interventions such as intravascular lithotripsy, provide powerful tools in our arsenal. These modern treatments, particularly the 2025 updates, highlight a shift towards more refined, risk-adapted care that promises improved patient outcomes. However, the foundational role of lifestyle modifications, including diet, exercise, and smoking cessation, remains paramount, directly addressing the underlying factors that drive these complex processes. Looking ahead, the commitment to ongoing research is critical. The promising avenues in antifibrotic agents, galectin-3 inhibitors, and regenerative therapies like stem cell and gene therapy represent the future of cardiovascular care, offering hope for not just managing, but potentially reversing, the structural damage inflicted by heart disease. Ultimately, a proactive and integrated approach, spanning prevention, early detection, and comprehensive treatment across all stages, is indispensable. By leveraging both established therapies and emerging innovations, we can work towards breaking the cycle of cardiovascular damage and improving the long-term health and well-being of individuals facing these complex heart conditions.